just join our hearts and with a clapping ovation on the chat page. Please can we welcome to speak with us Dr. Emmanuel Oduware.
Thank you very much. Good evening to everyone who's joining us. I do understand this was scheduled for last week. Probably at the end, I will just reflect on that. I'm glad to be with you today. So as quickly as I can, mindful of time, I'll be speaking on domestic opportunities within the Nigeria ecosystem, Nigerian healthcare and presence, domestic opportunities being the key word. Dr. Samuel Omomide has talked about leaving medical school, going through internship, and then youth service, the compulsory national youth service. And that's the usual trajectory of the average medical student or average doctor who finishes from medical school in Nigeria. The question usually is, what do you do after that? I used to say then, and many persons did opine then, that period, house job, youth service, like a hiatus, like a buffer period where you make decisions as regarding your trajectory. Where do I go from here? And I'm sure that some person are at that inflection point now where it's critical that you make a decision, because that could determine if you move in the direction that would ultimately ensure that you fulfill purpose upon the earth, or the cause the person go off on a tangent. Heavens forbid. As Christians, we're reminded that we are not just like every other person who's working. We have a purpose upon the earth, and that our profession and our lives and whatever we do with it is a vehicle for actualizing God's mandate upon the earth. We need to be mindful of that. We need to constantly remind ourselves of that. So it's important that we look at various opportunities that are available. Just Chris said, which of you wants to be the tower does not first sit down and count the cost? And that's part of what we're doing, counting the cost. Wherever you are in the cosmic realm, in this terrestrial plane, there are opportunities. And a SWOT analysis, there's the acronym strength, weakness, opportunities, and test and trust, helps to appraise the available opportunities that you can now harmonize or maximize to determine your trajectory. Right. So today I'll be fixating on domestic opportunities. I will just take them in an itemized, annotated form to make it a bit easier for us to delineate, and then later on we can now have some questions. So I'll just run through them. The obvious one is you leave medical school, you're done with internship, you're done with your service. The traditional trajectory afterwards is clinical, and by that I mean residency training. So the question would be, what path should I follow as per residency training? What I usually advise is consider two things. One, what's your temperamental suitability, your overall attitudinal disposition. And what I mean by that is that different specialties require separate and different temperaments. A lot of this has to do with introspection and self-discovery. Fortunately for me, I'd learned early on in med school that I was a generalist. I'm what we call an eccentric person. I get bored easily. So if I am not in any event that gives me a panoramic engagement, that's broad range engagement, I'll get bored. No matter how interesting that thing is for me at the outset, later on, that passion will just generally fizzle out. So I know it's my personality type. It doesn't mean I cannot work in that direction, but I will not derive as much fulfillment as if I was doing many things, you know. And the danger about doing many things is that you could lose your way if those things are not revolving around the pivot. So for me, I found out I needed to do something that had many things revolving around that pivot. Okay. And if I was doing surgery, for instance, now I was doing internal medicine, for instance, or obs and gynae or pediatrics, the traditional domains, whichever I was doing, I would get bored after a while. So I looked for what would orient me along those multiple trajectories, but have a singular pivot. And that's why I settled for family medicine. Much to many persons' surprise, because a lot of persons thought I would do neurosurgery or neurology. Matter of fact, a neurosurgeon had said, okay, I should do neurology. And neurosurgery, the neurologist said I should do neurology. And they're both like jostling for me to come to the programs. Eventually I settled for family medicine. Yeah. And I realized that's either going to be family medicine or emergency medicine that would suit me as per temperamental suitability, because I'm a generalist at core. So it's important to realize that whilst determining what clinical path you choose to follow. All right. The other not too taken path that's available domestically is academic. It was kind of more popular back then, but for some reasons, not many persons veer into the academics. And academics could that be in the preclinical levels or the clinical levels. So preclinical means that you left medical school. Some medical schools abroad, what they have is intercalated programs. So technically, because of the bulk of curriculum work you would have done in your preclinical school, you should be able to graduate with either a BSc in anatomy, physiology, or medical biochemistry. So because of that understanding, it is straightforward for the average medical doctor or dental doctor to decide to either pursue an academic path in anatomy, physiology, or biochemistry. And I have several colleagues who are in that path and are doing well. Some have even risen to the position of professors. So it's not a commonly beaten path, but I've seen quite a number of persons who pursued it and they're doing well in it. So I would advise that persons that you're interested in lecturing and you want to pursue that academic path, not necessarily in clinical disciplines, but in preclinical, that's really a regular opportunity. But again, like I said before, count your cost. It means that you have to be ready to become a university lecturer. And that comes with tons of work, load, teaching, certain exam questions, marking scripts. I keep saying that marking scripts is one of the things I find very, very challenging being in the academic sector. I can do many things. I can teach, I can lecture, can't even set questions, but I don't just like marking scripts. My mom's an educator. She was retired as a principal. So sometimes I had to assist in marking scripts, and that's been one of the challenges that persisted today. So it just doesn't stop me, but it's good to know what challenges come with each particular choice. The third one is research. This is a passionate thing for me, research. There is still large areas that are untouched regarding research in Nigeria. You did hear Dr. Samuel, when he was doing the introduction, talked about that I was reputed to have developed made the first genetic diagnosis of hereditary kidney disease. Now, that hereditary kidney disease, I'm sure a number of you know, is ALPORT syndrome. That's ALPORT. I hope you've heard of it, because I remember when the genetic result came to my phone via email, I was standing with the CMD and I think one of the clinical deputy CMACs of 𝐸𝐵TH then, and another hospital administrator from another hospital, and I showed them, and one of them later told me that was the first time we're hearing about that disease. So, and it's pretty rare. So ALPORT, ALPORT. If you Google ALPORT syndrome Africa, you would see my research work there. It's the first one. So it was the first genetic diagnosis of ALPORT syndrome in West Africa, and the first and the most recent in Africa. So because of that, I generally seen as a reference for ALPORT syndrome in Africa nowadays. So usually when they're conference like that, they invite me to have just give my perspective. And I just presented recently in Cyprus on a new template of national clinical guidelines management for hereditary kidney disease with source challenge settings using Nigeria as a case study. It's a multi-center pilot study beginning with 𝐸𝐵TH that's underway, being proposed now. So research is one very key area. And prior to making that diagnosis, of course, I've been taught in medical school like virtually every person. But I remember one of my juniors, one of the senior registrars, wanted me to review a case, and I felt it was boring. And well, one thing led to another. I had an inkling, and within 5 minutes, this was likely ALPORT. And then I had to pursue freighting the sample to Germany to have that test done. So why I'd mentioned that is, even though I was certain about my diagnosis, I needed something concrete, and I was able to pay the price. It cost me millions, literally, to get that diagnosis done, made, and then pursue the clinical treatment for the patients even till today. But it's because of that commitment that I've been able to make that impression within the world of research. It's important that you realize that, yes, I made that commitment to freight the sample abroad, but the fact that I already made the diagnosis from a research challenge setting in Nigeria, I could have pursued with that. I just wanted to make sure that there's no contention as to the certainty of the diagnosis. There's no thinking of a differential like thin basement membrane nephropathy or some other MYH9, many differentials for hematuria and glomerulonephritis, in the young. So I want to make sure that we're certain. But I could have stuck with the clinical impressions and then the proteinuria and all that I've gotten. So you can, with the resources we have, still make impactful diagnosis, still pursue clinical research work. The environments are challenging in Nigeria, but they also have a lot of positives. One positive I'll give you is that in Nigeria, you have access to a host of patients without so many bureaucratic bottlenecks. It's quite easy to pursue research if you're inclined towards it and you're interested in it. And not just because you want some glory, but primarily because you want to help the patient and you want to, for me, want to help the patient, but two, to contribute to the quotient of knowledge. What we practice today as evidence-based medicine, we're building upon layers and layers of research that have been distilled through the centuries. And that's what makes medicine more precise. And it's actually, medicine is not the precise science, but that's the aspiration. It's what makes medicine more effective, more precise. Our therapeutic modalities are much more better than they've ever been. The clinical approach to management is much better than it's ever been. And that's because of years and years and years of commitment to research, from Cochrane trials to systematic reviews to meta-analyses to randomized controlled trials, all manner of research, the translational and the impactful. So if you do have that passion, that's one thing I like doing. Even when I came here to where I'm currently now in the UK, I like to say I'm global, but I'm currently in the UK and I'm everywhere at every different point in time. So when I came here, my pursuit for that research oriented work, one of the cases I managed here was an acute coronary syndrome case, a myocardial infarction. I wrote it up as a case report and I went to present it in the US last year. My colleagues, my consultants, colleagues here, friends here, they're not really interested in some of them in that. So even whilst here, I still took a case and went to present in the US. Just like I presented in Canada, the case I had just diagnosed in Nigeria. So it's the mindset, whether in Nigeria or in the UK, in Canada, US, research is a universal language. Okay, I'll talk about that later on. The one I want to just devolve into and run off with that is entrepreneurial. That's a dimension that is often discouraged because of the different challenges that come with pursuing an entrepreneurial path. But within the medical ecosystem, entrepreneurial simply means do I want to set up a clinic? I wouldn't advise any person who's leaving med school internship, youth service to think too much about setting up a clinic unless it's in partnership. I would advise that you build some credence, some professional clout. MD rules even says that until you're 10 years post-graduation, you cannot independently supervise a clinic. All right. And there's delineation between what subsists as a clinic and what's a medical center and what's a hospital. So there's that compartmentalization within the health ministry as far as terminology goes. But when you set up a clinical setting, I would still advise that consider partnership. And if you're going solo, build enough credence and professional expertise first. It's important because medical profession is a very sensitive profession. We need persons who are committed, who are dedicated, and who are also very competent. All right. You might not want to open a traditional clinical setting like traditional hospital, but you might consider a diagnostic center. Now, that's irrespective of whether you're in the pathology disciplines. Diagnostics is one, let me use the word megabox spinning component of a hospital. I sit on the board of a private hospital in Nigeria. And I'll tell you that many other healthcare entrepreneurs will say the same thing. The diagnostics and, of course, pharmacy is one of the major portals of revenue inflows for any hospital. All right. And that includes laboratory, imaging, like ultrasound, x-rays, whatever. So you don't even need to be a doctor. You don't even need to be a clinician to set up a diagnostic center. There are many persons who are not clinicians who are running medical diagnostic centers, which include laboratory, include imaging, and the likes. And you can also pursue some niche areas within diagnostics. Okay, you can also set up separate therapeutic or treatment centers that are not holistic clinic based. For instance, it could be a dialysis center. There are there are areas that have not been touched yet with providing particular services. Okay, I remember accompanying a high-profile person in Nigeria to the US for treatment. I was accompanying physician, and some of the centers we just went to, all they do is just offer treatments. Okay, just a treatment outfit. So the centers like that, some are just emergency rooms. Okay, so you don't have to have the whole works. In case you're discouraged about having to have clinics and pharmacy and labs, and some clinics don't even have pharmacies. No, so the many varieties, the different dimensions of setting up clinics. Okay, one thing we don't consider so often is informatics. Many private hospitals, not even the top-notch ones, even those that are considered middle level, are quickly saying that the persons who are willing to pay for health services outside the public hospitals, outside the public sector, many of them demand a certain kind, minimum standard of service. Okay. And one key critical area is informatics. So if you do have interest in IT, the possible you always had interest in IT, information technology, and you were inspired to become a doctor by your parents, maybe your parents are doctors, or you just love the profession, but you're still having this conflict, struggling with how to reconcile your love or passion for information technology and clinical medicine or medical practice. Medical informatics is the way to go. And that includes electronic patient records, a lot of stuff that has to do with medical practice now is digitized. For real practice in the first world, that's usual, that's the norm. I mean, you see patients on computer system, lab results come on computer system, your x-rays come on computer system, CT scan images come on computer system in real time. It's the norm, that lovely web interaction and real-time interface. But that's becoming the norm in many private hospitals in Nigeria too. So that's one thing you could go into, and you could begin to patent your own peculiar diagnostic templates for electronic patient records, or just go about setting up this systems in different hospitals. I have friends to do that, and they're quite successful at it. And there's nothing that stops you from coding particular diagnostic software that have not even yet been discovered. I mean, there's some ideas that have been brooding in my head as regards IT. I don't want to mention it now because they're still in the infancy stage, and sometimes I try to just nurse them in that way until bust to the floor. You hear of some of them, but so within the healthcare ecosystem, there are a lot of information technology services that can be available. Now we're having point of care services. So those are things that have to do with innovation. Okay, so the network concept that you can go into if you're in that field. And do not think that because you're in Africa or you're in Nigeria, you're on the other side of the Atlantic, that you cannot do these things. It starts with drawing your designs. Now the world's globalized because it's digitized. That's an advantage. Drawing your designs, and then by the time you have a particular concept, you can patent it in the EU, patent it in the US, and then from there you just double it. I know someone who in Lagos is an engineer, patented a particular automated refueling system for vehicles, and it was patented in the EU and the US, but he's in Lagos. So these things are doable. He didn't need to travel to do so. These things are doable. You just need to be committed. All right. Okay. So the last one I'll just mention before we go into questions would be academies. There are a lot of persons who go into, some as a side hustle, some as their main thrust, going into setting up academies for training doctors to write professional exams. Professional exams, of course, most of them are foreign professional exams, but you can also do that in Nigeria. There are ways to, the Japa syndrome is real and it's on. And if you're that gifted, the persons who are gifted in sifting and mining several tomes of materials, past questions and all that. And I mean, the persons who, when we were in school then, the medical school, they have a way of aggregating several materials, past questions and all that, and aggregate it. And we're using discussion classes, and that was very helpful in many ways. There are also persons who are very good at tutorials, who are teaching, and teaching persons who are preparing for certain exams. So you set up academies that have to do both foreign exams, local exams, medical school exams. You could have your own academy. That's something you can start whilst in school, or better if you've left medical school that you want to create an academy. And before you know it, you're having multiple such outfits in different centers of the country, and then you become renowned. The way persons have pre-university academies, you can have academies that address postgraduate, maybe preparing for primaries, preparing for postgraduate exams, whether domestic or foreign. academies are becoming a big deal in the rest of the world. I can assure you, even for professional exams, they're becoming a big deal. Some are on telegrams, so that's another thing. You can have them on. You can have them. Good thing about social media now is that you can have many things, and not necessarily physical. You can have academies. Matter of fact, I've attended a number of training workshops now that are online. That's another thing that COVID gifted us as gifted to the world. We accelerated our path towards digitized platforms because of COVID. If without COVID, I might not be having this engagement with you because we would not have thought that Zoom or Teams or whatever platform you prefer using would have been feasible, certainly not at this space. So we can harness the opportunities, maximize the potentials we have. There are several things that can be done. I will just stop here for now. In summary of by recapping, we've talked on domestic opportunities in the healthcare space and the ecosystem. I'll take some questions now.